This is the part 6 video on gonioscopy. I'm gonna read Gonioscopy from Arvind's. And in the last video, in the last video we saw the corneal wedge, the gonioscopic landmarks. Now the second is level of iris contact looking over the hill. In some eyes, a convex iris profile can obscure a narrow gap between iris and trabecular meshwork when viewed in the primary position. That is, the angle will appear closed when it is not. There is always debate regarding how much an eye can be moved from the primary position in the assessment of an angle. A very gentle rotation of the lens may be all that is needed to look over the hill and confirm that there is no iridotrabecular contact, figure 8. However, if too great an off-axis view is attempted in order to look over the hill, then accidental indentation may occur with the edge of the lens and an artificially wider angle be seen. This is what is done deliberately when indenting with a Goldman-style lens. It is difficult to ask the patient to make small changes in direction of gaze to facilitate this. Movement of the lens is the best approach. Estimate width, iris profile and structure seen. Assessment of angular width is done by mentally constructing tangents to the trabecular meshwork and the peripheral iris and then estimating the geometric angle between these two lines. It may be helpful to envisage a 90-degree angle cut in half and remember that forms 45 degrees. The average or range, if it varies a lot, for each quadrant is usually recorded. It is usually possible to assign values of 0, closed, 10, 20, 30 and 40 degrees or greater in an aphakic eye, for example. Spade's classification uses the average of the peripheral third of the iris, whereas Foster suggests using the iris immediately adjacent to the trabecular meshwork and Charley's line. The overall iris profile is then described as steep, regular, flat, concave, or in a plateau configuration, and a record made of the deepest angular structure visible without indentation. The first gentle examination in the primary position is indented to determine the level of iris contact with the eye wall and the angular width of the antechamber angle. In the absence of iridotrabecular contact, the level of iris insertion is determined. If iridotrabecular contact is present, then it is important to determine whether this is purely oppositional, that is, it can be easily reversed, or synechal, that is, a permanent addition, indentation, or manipulative. Gonioscopy achieves this by applying pressure to the central cornea and so increasing the anterior chamber pressure and forcing aqueous fluid into the angle. This pushes the iris posteriorly and away from the meshwork in those areas in which it can separate, thus revealing the true point of iris insertion or the level to which abnormal adhesions have formed. Figures 10a and b. Additional signs of abnormal iris curvature or posterior structures, that is double hump or volcanosigns, also rely on indentation to be revealed. Indentation is best performed with 4 mirror lenses which have a smaller contact area. Traditionally, it was considered impossible to perform indentation gonioscopy with Goldman-style gonio lenses. However, it may be possible to indent and open many closed angles with a Goldman-style lens using 3 specific maneuvers. 1. Increase the illumination to a bright white beam falling onto the pupil. The patient refixates and looks towards the mirror of the gonioscope. The rim of the gonioscope over the mirror is rotated towards the patient to indent the central cornea. Note, in cases where all angle structures still cannot be visualized clearly, a 4-mirror lens should be used with gentle forward pressure to produce greater delayed central pressure. However, too great a pressure will distort the cornea and cause folds that obscure the view, and the lower magnification can make subtle signs harder to see. Standardize the examination routine. As with any clinical examination, it helps to develop a routine as you are less likely to omit something. For example, examine the superior and inferior then nasal and temporal angles in turn, and of course begin with identifying the corneal wedge, assess angle width, and then and only then indent. You must then remember the common mistakes and avoid them. Recording and classification grading schemes. There remains much confusion about different grading schemes. The choice is between one of the three S schemes and Foster's recent modifications. They are often confused. She describes the structure seen. Schaffer estimates geometric angle between iris and cornea. Spade describes features identified by She and Schaffer schemes as well as the iris profile and level of true and apparent iris insertions. Table 8, Figure 9. Foster's modified Spade. Spade's classification uses the average of the peripheral third of the iris, whereas Foster suggests using the iris immediately adjacent to the trabecular meshwork and shoulder line. This is because the most peripheral iris may be almost in contact but then very quickly diverge from the endothelium. The average value can therefore be misleading. To the original three grades of iris profile, steep, regular and concave, a fourth grade of plateau was added. The detail required varies with the clinical setting. The most detailed information is needed for careful longitudinal follow-up of borderline angle closure cases. Peripheral anterior synecchi are increasingly more common in eyes with a narrower geometric angle width. Angular width, thus, seems the most appropriate angle measure. A full assessment will include the angular width, the structure seen, the level of iris insertion, the iris profile, the presence, height and distribution of peripheral anterior synecchi, and the types and patterns of pigment seen. Foster's question for gonioscopy. There are 4 cardinal questions that need to be answered in angle closure gonioscopy, and the answers described as clearly as possible. 1. Does the iris touch the trabecular meshwork? 2. If there is no touch, is there evidence that it has been in contact previously? 3. If there is touch, is the contact reversible? 4. If the touch is not reversible, what is the extent of synechial contact, height, pattern and circumference? Pigment. Patterns of pigment deposition can vary a great deal, but also give useful clues to pathology. A wide range of mild to moderate intratrabecular pigment can be normal, while localized geographical blotches of moderate or dense milk chocolate pigment on the trabecular meshwork of eyes with brown irises is often a sign that intermittent angle closure is occurring. A dusting of dark chocolate granular pigment on the trabecular meshwork or iris or cornea zonal insertions is frequently seen with pigment dispersion and pseudo-exfoliation syndromes. It is homogeneous in pigment dispersion and patchy in pseudo-exfoliation syndrome. Common pitfalls and misdiagnosis in gonioscopy of angle closure. There are a number of common mistakes made in gonioscopy that can mislead the unwary. Careful identification of the corneal wedge and a high magnification view of the signs can help the observer avoid most pitfalls. Open or closed? One common error is to mistake a fully closed angle for one that is open, with a featureless page trabecular meshwork. In this situation, the corneal wedge would of course not be visible and an abnormally high point of iris contact should be detected. Pigment, normal or abnormal. Another is to misinterpret pigment smudging due to intermittent iridotrabecular contact and therefore pathological as normal trabecular pigmentation. Different races may show different degrees of pigment deposits in the angle, but pathological smudging is identified by its paler color, more similar to the anterior iris surface, and irregular geographical or blotchy appearance. Pigment in the superior nasal or temporal angles is of greater significance than that in the inferior angle, in which gravity may play a part. Peripheral anterior synecdoche. A further subtle sign of angle closure that is easy to miss are low peripheral anterior synecdoche pars that do not extend to the tubercular meshwork. These may only be detectable as localized variations in the apparent insertion of the iris on indentation of a narrow angle. They may be distinguished from physiological iris insertion variation by their greater variability in height and more localized nature. These subtle signs are revealed by careful comparison of the angles of each eye, which can also reveal certain degrees of angle precision that might in isolation be passed off as normal. Peripheral anterior synecdoche pars or iris processes. Table 9, figures 12 and 13. Mechanism of angle closure. Once angle closure has been detected and described, it is important to diagnose the mechanism and assess the contribution of pupil block and non-pupil block mechanisms. Pupillary block alone will lead to convex iris curvature or bombing. Pronounced iris bombing can obscure other mechanisms such as crowded angles, a prominent last iris roll, and various plateau iris configurations. It is also important to differentiate pupillary block and anterior non-pupillary block mechanisms, including plateau iris, from forward movement of the iris lens diaphragm, such as occurs in aqueous misdirection and other causes posterior to the lens equator. These cases are often unilateral and there will be a pronounced asymmetry of the central anterior chamber depths. Difference between neovascularization of angle NVA and normal iris vessels is discussed in table 10. Now figures and tables. Table 6. Table 6. Shear system of grading. Grade 0, 1, 2, 3, 4. 0. Ciliary body band C. No angle closure. Grade 1. Ciliary body band narrow. No angle closure. Grade 2. Ciliary body band not seen. Scleral spot seen. Rarely closure possible. Grade 3. Posterior tubercular meshwork not seen. Closure likely. Grade 4. Short line not seen. Gonioscopically closed. Now table 7. Schaffer and modified Schaffer grading of angle width. Grade 0, 1, 2, 3, 4. Schaffer, grade 0 closed. It is opposite to the shear system of grading in the sense the numbers. Means grade 0 corresponds to closed in Schaffer and modified Schaffer, while in shear, grade 0 equivalent to no angle closure and ciliary body band C. So it is opposite. The numbering is opposite. So in Schaffer, grade 0 is closed. Schwalbe's line not visible. Grade 1, 10 degree, grade 2, 20 degree, grade 3, 30 degree, grade 4, 40 degree. We have seen the similar classification, the same classification in the similar way in the Albert Jacob, volume 2. So Schaffer, grade 0 closed, grade 1 is 10 degree, 2 is 20, 3 is 30, 4 is 40 degree. It's easy to remember. And modified Schaffer, grade 0, Schwalbe's line not visible, it is closed. Grade 1, 10 degree, Schwalbe's line visible. Grade 2, 20 degree, anterior tubercular meshwork visible. Grade 3, 30 degrees, scleral spur visible. Modified Schaffer, scleral spur visible. Grade 4, ciliary band visible. Modified Schaffer, once again. Modified Schaffer, grade 0, Schwalbe's line not visible. Grade 1, Schwalbe's line visible. Grade 2, anterior tubercular meshwork visible. Grade 3, scleral spur visible. Grade 4, ciliary body band visible. So now Spade system of grading the angle. It includes peripheral iris configuration, then angular width of angle recess as we have already discussed currently, now only, as grade 0 to 4, that is Schaffer. Then level of iris insertion related to the iris iris configuration, level of iris insertion, then angle related to, and also iris processes, then then angular width of the angle basis, and pigmentation of the posterior trabecular meshwork. It's, you can say, the gradation or degree. So peripheral iris configuration, B equals to bows to 1 to 4 plus, usually indicative of optically appearing closure altering with indentation. P for plateau, comparable to older S designation. F flat approach, the commonest iris appearance comparable to the older, what is this, R designation. C concave, as in posteriorly bowed iris comparable to the older Q designation. So B, P, F, C. B bows to 1 to 4 plus, P is plateau, F is flat, C is concave. Then angular width of the angle basis 10 degree, 20 degree, 30 degree, 40 degree. It is similar to Schaffer's grading. Level of iris insertion, A, B, C, D, E. A is anterior to the shawl baseline, B is just behind the shawl baseline, C is at the scleral spur, D is deep angle, ciliary body band seam, E extremely deep angle. Once again, A is anterior to the shawl baseline, B is behind the shawl baseline, C is at the level of the scleral spur, D is deep angle in which the ciliary body band is seen, E is extremely deep angle. Iris processes, U, V, W. U is along the angle basis, V is up to trabecular meshwork, and W is up to shawl baseline. U, V, W. So U is along the angle basis, then V is up to trabecular meshwork, and W is to the shawl baseline. Iris processes. Pigmentation of posterior trabecular meshwork. 0 no visible pigmentation, 1 plus just perceptible pigmentation, 2 plus definite but mild, 3 plus moderately dense, 4 plus dense black pigmentation. So mild, moderate and dense. Mild is 2 plus, moderate is 3 plus, 4 plus is dense black. Mild 2 plus, moderately dense is 3 plus, and 4 plus is dense black pigmentation. 0 is no visible pigmentation, and 1 plus is what? Just perceptible pigmentation. So that was about the Spade system of grading angle, which includes peripheral iris configuration, angular width of the angle basis, level of the iris insertion, iris processes, pigmentation of the posterior trabecular meshwork is grading. Figure 9, Spade system of grading. Okay, so they have given the diagram of Spade system of grading. They have shown 10 degree and grade for 40 degree. Grade 1 is 10 degree angle. Now figure 10A and 10B. 10A is indentation gonioscopy. No angle structures are seen in figure A. B on indentation. All the angle structures can be visualized. Arrow. Note the corneal force on indentation. Means on indentation the angle opened. Schaffer's classification system. Grade 1, 2, 3 for corresponding to 10 degree, 20 degree, 30 degree, 45 degree angle. That is the angle that is in between the tangent drawn to the corneal endothelium and antisurface of the iris. That angle we are talking about. Now table 9, gonioscopic difference between iris processes and peripheral anterior synecdoche. Features, iris processes and peripheral anterior synecdoche. Shape. Iris processes, these are fine and lacy. Peripheral anterior synecdoche, these are broad and irregular. Iris processes normally fine and lacy. Peripheral anterior synecdoche, these are broad and irregular. Extension is up to inferior portion of the trabecular meshwork iris processes, while peripheral anterior synecdoche can go up to the shawl baseline. Spatial feature, follow concavity of the recess. They follow the concavity of the recess, and peripheral anterior synecdoche, they breach the underlying structures. During indentation gonioscopy, they do not inhibit the movement of the iris. And during indentation gonioscopy, peripheral anterior synecdoche, they drag the iris vessels with them, obviously, because it's a synecdoche addition. Interference with absent, interference with is present. I don't understand this. I didn't get what they mean by interference with. If anyone knows, they can tell me in the comment box. What do they mean by interference with absent, interference with present? I didn't get that. I didn't get that line. Now figure 12a to C, peripheral anterior synecdoche pass. Figure A to C. So peripheral anterior synecdoche, these are broad and irregular, and iris processes are fine and lacy, and peripheral anterior synecdoche, they extend up to the tubercular. They can extend up to the Schonberg's line, while they hardly cross the sclerus for and tubercular mesh with iris processes. And they drag the iris vessels with them, the peripheral anterior synecdoche. They don't do that on the intentional gonioscopy. Who don't do that? Iris processes. Now figure 13a and B, gonioscopic view of prominent iris processes. 13a and B, gonioscopic view of prominent iris processes. Okay, so you can see the differences between the iris processes in figure 13a and B and the peripheral anterior synecdoche given in figure 12a to C. Figures 12a to C. Table 10, angle blood vessels, normal vessels and neovascularization. Normal vessels is a radially oriented peripheral iris, circumferentially oriented ciliary body, and neovascularization, these are fine branching, usually cross the scleral spur, and normal vessels, these are thick, these are non-branching, fine are neovascularization vessels, and these are thick. Normal vessels are thick, non-branching, radially or circumferentially oriented. They do not cross the scleral spur. They cross the scleral spur, they are fine and branching. So that was all about gonioscopy. Today I'm going to conclude it here. Only 2 pages are remaining, I think. Yeah, 2 pages are remaining. Other uses of the gonioscopy. In that, I'll talk about the laser. In other uses of the gonioscopy, I'll also talk about the laser trabeculoplasty, laser goniotomy, laser iridotomy also I'll cover so that we can compare the procedures. And laser trabeculoplasty, laser goniotomy, and cyclophotocoagulation, if the time permits and if my memory is there available, I'll also talk about the cyclophotoablation, laser cyclophotocoagulation in short tomorrow. I'll cover these procedures under the heading of other uses of the gonioscopy. Ideally, I should cover only the trabeculoplasty and goniotomy, cyclophotocoagulation, cyclophotoablation, and iridotomy I shouldn't cover under this, but still I'll cover just to compare these procedures, laser procedures in glaucoma. Later, when I'm about to finish the management of the glaucoma, I'll talk about the surgical procedures and laser procedures in the glaucoma. Then I'm again gonna talk about all the procedures and compare these procedures with each other, like their parameters. So that was all about the glaucoma. I'm gonna add nice videos given on the www.gonioscopy.org. That site is good and you should go through that site. It will take the entire day. You can take the entire day, or you can just give 1 hour or even 5 minutes a day, so that you can cover all the videos on the gonioscopy. They are so nice. You can just see it daily, like even for 10 minutes, and you can cover the gonioscopy in just 15 days. Or you can just sit in a one day and go through all the videos. Like you can take 12 hours, whatever, 12, 14 hours. Like you watch movies and you just gossip rather than doing that thing. If you go through those videos, they are excellent and they are nice and they are useful. Like gossip is just useless. So that was all about gonioscopy today. Still one part is remaining that I will cover tomorrow. And after finishing the laser procedures and other uses of the gonioscopy, the day after tomorrow I can start with history of gonioscopy. I'll just make it interesting. I'll just add some scientist pictures given on internet. I don't know how much uh, information is reliable on the Google about the history of the scientists and their inventions, because I remember, because history is manipulated by the cunning people, because they want to portray themselves as heroines, and the savior of the world or savior of the human population, whatever it is, and they want to portray. Nobody wants to portray themselves as a villain. So I don't. I don't completely believe in the history that is written in the textbook, is given in the textbook, or even on the internet, because it is manipulated by so many people in the power, and what kind of people are in the power position even in today's era, and even I think recent few centuries, what kind of people are there and how they use their power, we can see. So yeah, but if the information is true, and I'm very grateful if the information is true, and if they have really invented these procedures themselves, or whoever invented these procedures, I'm very grateful to them, because it's very beneficial to the patients, and they suffer. Glaucoma is, I think it is more serious disease than cataract. Cataract you can operate, but glaucoma once, because I have seen one patient. That patient had not taken medications for 3 months, and his vision was lost completely, and you cannot correct it, you cannot reverse it back. At least with mature cataract you can do the surgery and you can just reverse that completely gone sight, perception of the light, completely gone sight back to the normal, even like back to the normal like 6/6, but 20/20. But this man, I felt very bad, and he was like, he was 65, 70-year-old, or maybe 70, 80-year-old man. I felt very sad, I felt very compassionate for him, because he didn't take the glaucoma medications. He was diagnosed with the glaucoma. I think it was advanced, moderately advanced. I don't know if it was moderate to visual field defect. I don't know, but he told me that he didn't take medications for 3 months, and he could see properly, he could walk, he could talk, he could do work, and in 3 months, as he didn't take the medications, all of a sudden, he discovered, all of a sudden, gradually over 3 months, he discovered that his vision was diminishing, and he didn't take the medications, he didn't approach also. So, poor people, uneducated people, they're ignorant. That which can be saved now, it can be reversed. Some things can be reversed, but some things are like they cause a permanent damage because of our ignorance or other people's ignorance. Then permanently damaging. So I feel you should be aware, and you should gain knowledge as much as possible and make your lives healthier and better. Thank you so much for listening to me patiently. Bye. Good night. I forgot to mention one more thing which I wanted to add in this video. That is neovascularization of iris and neovascularization of the angle classification by Weiss and Gold. So Weiss and Gold, they classified neovascularization of the iris and neovascularization of the angle in 1978. So NVI grading is as follows. Neovascularization of the iris grading is as follows. Grade 1, fine surface neovascularizations of the pupillary zone of the iris involving less than or equal to 2 quadrants. That is, pupillary zone of the iris involving less than or equal to 2 quadrants. Grade 2, surface neovascularization of the pupillary zone of the iris involving more than or equal to 2 quadrants. Pupillary zone involvement of the iris involving equal to or more than 2 quadrants. Then grade 3, in addition to the pupillary zone, neovascularization of the ciliary zone of the iris and or ectropion UV involving 1 to 3 quadrants. So ectropion UV or Neovascularization of the ciliary zone of the iris involving 1 to 3 quadrants. Grade 4 is neovascularization of the ciliary zone of the iris and or ectropion UV involving more than 3 quadrants. So grade 1 is pupillary zone involvement less than or equal to 2 quadrants, pupillary zone involvement more than or equal to 2 quadrants, then ciliary zone involvement more than equals to 1 to 3 quadrants or ectropion UV involving 1 to 3 quadrants, then grade 4 involving more than or equal to 3 quadrants, that is ectropion UV and ciliary zone involvement. Now neovascularization of the angle grading is as follows: 1, 2, 3, 4. Grade 1 means find neovascular twigs, cross scleral spore and ramify on trabecular meshwork involving less than or equal to 2 quadrants. Grade 2, neovascular twigs, cross scleral spore and ramify on trabecular meshwork involving more than or equal to 2 quadrants. Grade 3, in addition to the trabecular meshwork, peripheral anterior synecdoche involving 1 to 3 quadrants. Grade 4, peripheral anterior synecdoche involving more than or equal to 3 quadrants. So NVA grading is grade 1 means neovascularization extending to scleral spore and ramifying on the trabecular meshwork involving equal to or less than 2 quadrants. Grade 2 is neovascularization on the scleral spore ramifying on the trabecular meshwork involving more than 2 quadrants. Then grade 3 is trabecular meshwork, peripheral anterior synecdoche involving 1 to 3 quadrants. Then grade 4 is peripheral anterior synecdoche involving more than 3 quadrants. There is a nice chart. I guess grade 4, as per this chart, I have not referred any standard book for this. I searched for Arvind's glaucoma. Once I come across the standard book, because I see the grade 4 here, it is like less than or it's like more than or equal to 3 quadrants, and again it is in grade 3, it is 1 to 3 quadrants. So I'm not very sure about reliability of this source. These are the articles I have referred for this grading. In Arvind, I searched in neovascular glaucoma chapter. There I didn't get this grading, so I'm not very sure about this 1 to 3 quadrant, grade 3 and grade 4, about neovascularization of the iris and neovascularization of the angle, because it's involving like 1 to 3 quadrants and more than or equal to 3 quadrants, grade 3 and grade 4. It's not like a clear-cut demarcation between these two. So yeah, next to this I'm gonna add videos on neovascularization of the iris, peripheral anterior synecdoche, then iris processes, then plateau iris syndrome, and the Schaffer's grading that is included in the SPADE system only. So these most videos I have got from Gonioscopy.org site, and other videos, one video I have taken from YouTube. One of my favorite YouTuber, ophthalmologist YouTuber. His videos are very nice on gonioscopy that I'm gonna add. So I hope it will help you to understand gonioscopy and the findings of the gonioscopy in a better way. Thank you so much. Bye. Good night.
A talk about grading the angle. There's a wonderful talk by George Spaeth. I'm putting this in here because it covers other grading systems, and I have some really nice illustrations about the Spaeth and the Schaefer system. So it's important to have a grading system to document your gonioscopy findings, to allow you to follow changes in angle configuration and pigmentation, and it permits communication between providers. There are some systems that I'm not going to use, but I'll just mention them briefly. There's the Shea system that dates back to the 1950s, and it's confusing because it's opposite of what we typically use, in that a grade 4 in the Shea system is completely closed. And in most systems, grade 4 is wide open. So I just mentioned that as a historical fact. And some people use visible structures. So they will say open to ciliary body band, or open to scleral spur, open to trabecular meshwork. And I'm not going to talk about that system either. I'm going to really focus on two, and especially on the Spaeth system, because I like it very much. And I just want to give some credit to Lee Allen, who made these amazing drawings, and to my daughter, who turned them into the illustrations in this talk. So the Schaefer system is based on angular width, and it's like you just measured the angle between the cornea and the iris. Easier said than done, because it's not that easy to measure an angle when you're looking at it from inside the angle. But this is the Schaefer system. And this angle, which I measured with the protractor, is 25 degrees, which would be grade 3 in the Schaefer system. So in that system, grade 4 is 35 to 45 degrees, and on down, as you can see there. Really, the easiest way to remember it is if you just drop the last digit from the angle width. You're pretty close to the Schaefer angle. So if it's 20 degrees, that's grade 2, 30 degrees is grade 3, roughly. So drop the last digit. You can see that grade 1 and slit are probable angle closure, grade 2 possible angle closure. The Spaeth system is based on the fact that if you have a 25-degree angle, it makes a big difference on where the iris is inserting and what the shape of the iris is. And so Dr. Spaeth came up with this system that includes these three elements: the level of iris insertion, angular width in degrees, and then a description of the contour of the iris. It also allows for indentation findings, which is helpful. And this is the system that I use, that I have my residents and fellows use, and that I recommend. So the first is a letter, a capital letter, and that describes the height of the iris insertion. So A would be anterior to Schwalbe line. You can see that with the exception of C, the first letter of the description is a letter that we use to describe it or to grade it. So A anterior to Schwalbe line, that's closed, right? So there's no visible angle structure. Just an example of what that might look like. B is behind Schwalbe line, but in front of scleral spur, so it's inserting somewhere in the trabecular meshwork, like that. C, we use the second letter of scleral spur. C is at scleral spur, so the entire trabecular meshwork is visible, but nothing deep to that, like in this picture on your left. Then D is deep, sort of typical myopic angle where you can see ciliary body face quite clearly. So here's scleral spur, and here's ciliary body face. So that's a D, or deep angle. And then E is extremely deep, like this. So that might be somebody who's highly myopic. That would be an angle that is recessed. That would be an E. So A through E describes the height of the iris insertion. Then the next is the angular width. And Dr. Spaeth specifies that you measure the angular width 1/3 along the length of the iris. So because it makes a difference in some eyes where you're making that measurement. And so here you can see in the illustration, the third of the way out, we're making this measurement. And as I said earlier, this is 25 degrees. And lastly, we talk about the contour of the iris. This is an iris that is flat, relatively flat. It's not bowed forward or back, so that would have a small f. This is pupillary block. The iris is bowed forward. That would be a B. This is someone whose iris is bowed backward, concave iris, or a little C. somebody who would have, for example, pigment dispersion syndrome. And then plateau iris, where there's this double hump configuration, this fullness in the periphery. Central chamber is pretty deep, but there's this fullness under the iris in the far periphery. And then we grade the pigment. 0, pretty obvious. Trace of pigmentation, we can see right here. Grade 1, grade 2, 3, 4. This is a brown sugary kind of grade 4 angle like in exfoliation syndrome. This is a black magic marker line, also grade 4 in pigment dispersion syndrome. Obviously there's a lot of variability in how one would view a grade 2 versus 3 versus 4, but that's the scheme. And so just a few angles to look at here. This is an eye in which the iris inserts pretty close to scleral spur. We have 2 extra pigment lines up here. You can see the corneal wedge comes together right there. And so this angle would be a C. It inserts at the scleral spur. It's 50 degrees. I actually measured all of these. And there's 3+ pigmentation. These are Sampolacci lines. So C50, F, 3+ pigmentation. This is that same exfoliation picture that I showed you. You can see a little bit of the ciliary body here. So this would be a D. It is flat. It's wide open, so 45 or 50 degrees, and 4+ pigmentation. So I would just write that in the chart as D50F4. I wouldn't put the word pigment in there. This is an angle that's also inserting into the ciliary body face. Here's scleral spur, ciliary body face here, 2+ pigment, maybe even 3+ pigment, flat iris, so D45F2. Really, really deep angle, either high myopia or angle recession. So this would be an E. The iris is flat, it's at least 45 degrees. We rarely write a number higher than 45 because real honestly the difference between 45 and 55 in terms of risk of angle closure is 0. So E, 45 or 50, F for flat, 0 pigment. This is an angle that inserts right at scleral spur. You can see that the angle width is wide. There's no pigment. Interesting thing about this iris is just how flat and featureless the iris is. This looks like a Fuchs heterochromic iridocyclitis to me. I don't really know what Lee Allen was drawing here. So this is a C, inserts right at scleral spur. We don't really see much of any ciliary body face, 50 degrees, flat, really flat, and no pigmentation. This is inserting into the trabecular meshwork, so it's a B, again wide open, flat, no pigment. Patient with pigment dispersion, so this is an E, extremely deep. This is all ciliary body face right here, way more than 50 degrees, concave, 4+ pigmentation. So E60C4. The space system is also nice because it can display information from indentation gonioscopy. For example, this is somebody whose angle looks closed. When I indent in this view on the right, you can see the trabecular meshwork. So in parentheses, A, it looks like it's closed, but C, it opens to scleral spur. Scleral spur being right here. It might be a B or a C. 15 degrees, just a guess of how narrow that angle is. B because it's bowed forward, and we can see the pigment is grade 3. So the appearance of the angle is in parentheses, and then the second letter is what it looks like indented. One can also grade the angle with the Van Herk test. Really, this should only be used to confirm gonioscopic findings or to get the initial view as you're doing slit lamp examination prior to gonioscopy. But sometimes it's really hard to tell if the angle's closed or if it's wide open and there's no pigmentation. So the Van Herk can help with that. And the idea is to bring a bright light in from the side, and you just want to look at it when it first reaches the anterior chamber. So dark room, very thin, very bright light. I'm bringing it in from the side here. We use the thickness of the cornea as a ruler and then measure the anterior chamber depth as compared to the corneal thickness. So here we stop the movie. That's the corneal thickness. This young myopic patient has an anterior chamber that's way more than the corneal thickness. So this is a very wide open angle. Patient with traumatic injury, you can see the sphincter tear there. This is a person with angle recession. Again, we put on the thin beam. There's our ruler measuring the corneal thickness, and then we have this incredibly deep anterior chamber. This is an angle that's very narrow. So there's the ruler, and you can see way, way less than a third or even a quarter of corneal thickness deep there. And there are even areas where there's iris touch. And lastly, an angle where there is no anterior chamber. Iris is right up against the cornea. So in the Van Herk, if it's greater than a corneal width, that's grade 4. And you can see on down the line here. The Van Herk was really important back before there were 4 mirror lenses and Goldmann 3 mirror lenses because direct gonioscopy was so cumbersome. And today it's more just an adjunct to gonioscopy, not a replacement for gonioscopy. So just a review there of how to grade the angle. I would encourage you to try to learn the Spaeth system. I think it's the most descriptive and most useful technique for grading the iridocorneal angle. We're very fortunate to have a lecture on the Spaeth grading system by George Spaeth himself. Dr. Spaeth has contributed a longer lecture on gonioscopy, which is found elsewhere on this website, but I've extracted the portion that deals only with his grading system to include here. I would encourage you to look at the entire lecture under the introduction heading.
There are 3 dimensions in configuration that you have to consider. You have to consider this angularity, also where the iris sticks on. Does it stick on there at Schwabe's line, or does it stick on back there in ciliary body? As in this case too. And then you also have to consider the curvature of the iris. So, angularity, insertion, and configuration. Is it curved or is it flat? Now, this gonioscopic grading system is a method of considering all those aspects quantitatively and then putting them in a system which is easy to remember and which will be easy to record. First, let's talk about the iris insertion. There are 5 different places that we've described that. One is A, anterior to Schwabe's line, B, behind Schwabe's line, and B, by the way, is the weakest part of this whole system because behind Schwabe's line encompasses a lot of important areas. C, one can see scleral spur, but nothing behind scleral spur. So a B angle is between scleral spur and Schwabe's line. So a B angle could be closed, or B angle, if it was adherent up here, or B angle could be open. But a B angle shows that the iris insertion is between scleral spur and the anterior trabecular meshwork. Excuse me, and the Schwabe's line. Okay, D for deep. D means one can see the ciliary body, the anterior portion of the ciliary body. E is extremely deep. So in an E angle, one can see approximately 1 millimeter of the ciliary body. So this is the iris insertion. A, anterior to Schwabe's line. B, behind Schwabe's line. C, scleral spur is visible. D, ciliary body is visible. E, 1 millimeter of ciliary body is visible. That's the iris insertion component of the configuration. Then there's the angularity, the part that's considered in Schaefer's system. And this needs to be considered by thinking of a tangent to the posterior surface of the cornea and a tangent to wherever the iris is. This can be pretty accurately evaluated. Grace Owen and I did a study which we reported in the Transactions of the American Academy of Ophthalmology, which we used UBM to validate what the actual angularity was, and then we used gonioscopy, and we found we could quite reliably be within 5 degrees of what the UBM found. Interestingly, I tend to overestimate, and Dr. O tend to be a little bit underestimating. So if one is going to use this system, probably it's a good idea to validate your ability to do this with some UBM patients in order to make sure that you can get that fairly accurately. It doesn't have to be more accurate than that. That's plenty good. What we're really interested in is not whether it's 5 or 7 or 10, but is it 5 or 20? So there's some range of variability, but the amount of variability doesn't need to be excessive. So this is simply looking at the angularity by creating a tangent on the posterior surface of the cornea and then a tangent on the anterior surface of the iris. Second component, the angularity of this angle. Third component, this has to do with the curvature of the iris. And this is an essential part. Now, this was not my contribution. It was originally described by a great gonioscopist from South America, Busaka. And he described this many years ago in his wonderful atlas of gonioscopy. It's an interesting phenomenon, why so many things are described and ignored. This is a really essential part of describing the anterior chamber angle. Why was it that nobody paid any attention whatsoever to Busaka's important contribution? That's a subject for another lecture. But when I first started this, I used different letters, but some people found them confusing, so we've changed these a little bit, and what we used to call an R for regular, we now call an F for flat, because that flat, of course, can be this direction or it can be anywhere, but there's no bowing to the iris. It's a flat iris. In contrast, when the iris has a rather regular bow, could be slight, just a little bit bow like that, or it could be marked like this, then that's put down with a lowercase b. So this is lowercase f for flat, lowercase b for bowed. A plateau iris in which there is a sudden steep rise and then it flattens out. Definition of a plateau is designated by a P, P for plateau. So plateau iris, sudden steep rise and then flat. And an iris which bows posteriorly, so it's concave, is the C. Now, I want to go back a little bit because is it important to understand whether there really is an A or B or C or D? Does it matter? Well, yes, it does. It matters not only because of the presence of, obviously, anything anterior to a C is pathologic, but also, way back here, it also matters because certain types of angles are characteristic of certain ethnic groups. In Caucasians, most Caucasians, the angle tends to be more deeply inserted. In brown-eyed Caucasians, it tends to be a little more anteriorly inserted. Patients of African extraction, it's a little more anterior than in most Caucasians. So let's continue on with this now to show how these are put together into a grading system. So now we have an angle that looks like this. And first of all, let's just describe it. The iris inserts into the ciliary body, anterior ciliary body, so that would be a D. It bows anteriorly, markedly, but flattens out, so that would be a P, a plateau. The approach to the angle is probably somewhere around 30 degrees, so that's a 30 degree. But we don't have it written down that way. Why do we have it written this way, and what does this mean? Well, on looking at this angle, the view through the angle, one cannot see past the posterior terrestrial meshwork. So this looks like a B angle. Looks as though the iris is inserting somewhere around here. So we call this a B angle. But it's not a B angle. So this is put in parentheses, because in actuality it's a D angle, which you can only tell from Max Forbes' indentation gonioscopy technique. So when you push on the cornea, you displace the aqueous. This increased pressure here pushes this iris back. There's nothing to support it there. So the iris gets pushed back. You end up then with an iris that bows posteriorly. You know that's a D. Now, are there disadvantages to gonioscopy done with an indentation technique? Yes, there are. There are major disadvantages. And David Campbell, great gonioscopist, great contributor to the field also, was not a fan of indentation gonioscopy. He said what happens is people push against the cornea and they inadvertently deepen the anterior chamber and make the angle look deeper than it really is. A real danger. One of the ways one can avoid that is by insisting on gonioscopy that you see absolutely clearly. Because if you're indenting, you're bending this a little bit, and you tend to get striae, and you don't see so clearly. If your view of this angle is not absolutely crystal clear, insist on knowing why. Is it due to a corneal dystrophy, corneal guttata, By the way, gonioscopy is a really nice way to look at cornea vittata. Is there some other media problem, or are you creating an optical media problem by pushing on the eye, bending the cornea, and then not seeing the angle as clearly as you should? So with an indentation gonioscopy, you have to be very, very gentle. Just touch that cornea. Now, the way I put on the lens in patients when I use the indentation lens, which is what I use routinely, is you're seated at the slit lamp. You don't look around the side of the patient as you do when you're putting on a Goldman. You're seated at the slit lamp, you're in focus, you've got the oculars in focus, the patient's anesthetized, and you tell the patient, now just look straight ahead. You're going to feel this, but it won't hurt you. Then with them looking straight ahead, looking through the microscope, you place the mirror on the cornea. The immediate response, the patient's going to squeeze. So for a moment, you have to hold it quite firmly, because you have to hold it firmly enough that when the lids come down around the mirror, it doesn't pop that out. But that firmness will be much too firm to allow you to see well. So once they've blinked a couple of times, then they start to relax. Then you pull back until you get a little bit of a bubble, so you know that you're not in contact with the cornea anymore. Remember, of course, with an indentation technique, you don't use any gonioscopic gel. That's one of the other advantages of it. So you're not using any gel, so you very quickly lose contact. So you pull that back, then you just hold it feather touch on the cornea. Then I usually start with looking at the inferior angle, so I start with the superior mirror because it's usually a little deeper, a little easier to see the landmarks inferiorly. So I look at the inferior angle, then crank it up, look at the superior angle. Usually you don't need to look at the temporal and nasal angles. Sometimes you do if you're looking for fine blood vessels and Fuchs, or for cyclodialysis cleft, or for an angle cleavage. Yes, there are lots of times when you're going to need to look at the 3 and 9 o'clock position, but by and large, the two areas that you need to look at and that will be adequate for almost all gonioscopies are the 12 o'clock position and the 6 o'clock position. So, now got the lens on there, and you're looking, and what you see is you can't see past the posterior tract meshwork. So you say in your mind, B. Then you indent and you see, whoop, it's actually a D. So now you say parentheses B and parentheses D. It's a 30 degree, it's a P. Then you do that at the 12 o'clock position. Then you record it. And the way you record it is simply by, I usually draw a circle if the angle is different in different parts. If it's all the same 360 degrees, I just write down parentheses B and parentheses D 30p. So there you've described the entire angle. You've said exactly what it's like, and it's taken you, 10 seconds to write it down. That works in a busy clinical practice. Now I have something else on here too, 0 PTM. And we'll get into this before we go into the next part of the grading. One of the thoughts I'm going to try to leave you with is that gonioscopy is not going away. UVM is great, but it doesn't tell you what you need to know in most people. Visati OCT won't tell you what you need to know because they don't tell you anything except this configuration. You also need to know what the posterior trabecular meshwork looks like. Is it pigmented? Is it not pigmented? What color is the pigment? Is the pigment different at the 6 and 12 o'clock positions? For example, an interesting phenomenon I don't understand, but in patients with the exfoliation syndrome, the pigment tends to be blackish and with the pigment dispersion syndrome tends to be brown until it gets very dense. Furthermore, with the exfoliation syndrome, the pigmentation of the posterior tract meshwork is more intense inferiorly, whereas in pigment dispersion syndrome it's more intense superiorly. So we also need to know the type and the amount and the position of the pigmentation in the posterior tract meshwork. And I don't usually, oh, this is a typo I see, it's PTM, of course, not PMT. So 0 PTM would be no pigment in the posterior tract meshwork. Now let's look at another case. So here's a patient now who, when you put the lens on, you can see this is deep. It's almost an E. That would be one of those places where you decide, well, is that a D, is that an E? It's certainly very deep. Along that line, who else has angles like this? In what sort of situation are you likely to see a very deep angle? Any patient who is a myope. Myopes usually have very posteriorly inserted angles. Hyperopes have much more anterior inserted angle. So here is a D, and here, well, it's hard to say, maybe even more than a 40, maybe it's a 50. It's clearly a very deep angle, and the angle is posteriorly concave. And there is very dense pigmentation of the posterior tract meshwork, so it's a D40C with 4 plus PTM. Now let's see, I've got, yeah, we'll just go back on that. So those are the two extremes of gonioscopy, the B angle. Okay, let's go back now and hypothesize for a moment. Let's say the angle, instead of coming up like this, the angle went right across like that. What would that be graded?
Plateau.
No, that's not plateau. Angle sticks there, goes right across it. This is a plateau. That's a plateau. What would it be if it's stuck there and just goes right across like that? A, 40, F. A40F. What's the diagnosis in a patient who has an angle that's an A40F? Of course it's angle closure. But what kind of angle closure? Would that be primary angle closure?
Would be a synechial.
No.
Opposition.
Of course it's synechial. But what's the diagnosis? What's the most likely cause for an A40F angle?
A secondary.
Neovascular glaucoma. Almost 100%. Not always, but almost certainly. That would be a neovascular glaucoma. Now what if you saw an angle in which it was rather like this drawing of Max Forbes, in which, but it wasn't quite like this, it was deep in some places, and other places came way up like that, all sorts of ratty PAS. What's that likely to be?
An axon field fever.
Chandler syndrome, or uveitis. So, depending upon where that is, it's very easy to grade that by just using those few descriptors, and that will give you a complete description of the configuration, but you also have to include, as I say, other aspects such as the amount of pigmentation of posterior tract meshwork. If that varies from one place to the other, just draw a circle and put the denominators either over the, 6 o'clock, 12 o'clock, or wherever it is that you need to do that.
This is a normal B40F angle. I don't indent, so I really can't judge the pigmentation in this angle. You can see that the iris inserts into the trabecular meshwork. We don't see scleral spur or ciliary body face, just the anteriormost portion of the trabecular meshwork. With the corneal wedge, we can identify Schwalbe's line, and we can see that Schwalbe's line lies anterior to the iris plane, but not much anterior to the plane. The iris insertion is relatively flat. Here at a higher power again, the corneal wedge, which is a little faint in this video, shows us that there is some trabecular meshwork visible, but only the anteriormost portion of the trabecular meshwork. The pigmented mesh is not visible, nor is the spur or ciliary body face. In this video, we see the normal angle of a myopic young patient. There's the iris, a moderately wide ciliary body face, scleral spur, a lightly pigmented meshwork, and here's Schwalbe's line. By the Spaeth classification, we would call this a D, because it inserts deep into the ciliary body face, an angle of 40, a flat iris, and 1+ pigmentation. This is a markedly concave iris in a patient without pigment dispersion, a young patient. You can see as we put a slit beam on here, it accentuates this concavity of the iris. But there's no pigment dispersion here. You can see the angle is unpigmented.
I have got different type of...
As this eye with a closed angle is indented, one can see periodic areas of adhesion. This patient had a history of having a laser trabeculoplasty, and these may be areas where the iris was welded to the iridocorneal angle and the cornea. This brief clip shows some low-lying peripheral anterior synechia in a patient with chronic inflammation. We can see that the synechia leave gaps in the trabecular meshwork that are open, and they bring the iris up to the cornea. Because it's a short clip, I'll show it again here. Synechia are different than iris processes in that they bring the iris tissue up to the cornea, whereas iris processes tend to follow the curvature of the sulcus. This is a rather remarkable video of a 52-year-old man with neovascular glaucoma from juvenile diabetes. He's recently had corneal decompensation that is resolving, but this left him with a small hypopyon that is going away. Remarkably, you can see neovascularization that is visible on slit lamp examination as a red stripe in the far periphery. This goes 360 degrees around his cornea. On gonioscopy, one can see this lush network of vessels in the angle. Again, this goes 360 degrees. Here inferiorly, we see this hypopyon that is much better than it was a few weeks ago. We can also see synechia that are developing in this area. I will now go to higher power and continue touring around the angle, looking at this lush network of vessels that fills the angle for 360 degrees. I can't recall seeing anyone in the past who had neovascularization of the angle that was visible so clearly on slit lamp examination. It's also remarkable that his iris elsewhere is not strikingly affected by neovascularization. We feel that this patient has ocular ischemia beyond his neovascularization from diabetes because he had a painful eye that remained painful even with a pressure of 25 millimeters of mercury. This patient has had multiple surgical procedures for glaucoma. When we look at the inferior angle, we can see these intermittent peripheral anterior synechia. We know that these are synechia because we can see the pigment anterior to the adhesion on the cornea. This patient has a rather rare condition of adniv. You can see he has low-lying synechia inferiorly. There's a synechia just over his scleral spur, but not quite to the pigmented meshwork here, and another lower synechia next to it. Superiorly, he has adhesion of his iris into his old cataract wound. Just a brief clip with some examples of synechia of different heights. This 80-year-old woman who is hyperopic was found to have narrow angles. You can see that the angles are quite narrow here, but when I indent, she has multiple synechia visible only on indentation. Again, I let up here, synechia disappear, and as I push, one can see several tent-like synechia. As I release the pressure, we develop more obvious apposition. But with indentation, we can see that there's not only apposition, but an intermittent synechia in this particular individual. Here again we see the angle indented. We can see very deep into the angle when we indent, and then when we release on the pressure, the angle again closes.
This eye illustrates two different stages of neovascular glaucoma. First on the right, the angle is already closed by synechiae. Here, an earlier stage with an abnormal vessel radially crossing the scleral spur, branching onto the trabecular meshwork. The pressure is already elevated with corneal edema explaining the hazy view. In the superior angle of the same eye, we see the same sort of abnormal new vessels radially crossing the scleral spur.
After a sudden rise in intraocular pressure, the eye of this 57-year-old man was found to have extensive neovascularization of the angle as seen here. He had already had 2 sessions of panretinal photocoagulation in the past. But here we can see marked neovascularization, although the angle remains open. The blood vessels cross the scleral spur, cross the trabecular meshwork, and branch, and are seen 360 degrees without any synechia. The patient underwent further panretinal photocoagulation that day and subsequently a week later. This video is now from 2 weeks later, and while one can still see the occasional vessel, they certainly do not look active, and the number of vessels has diminished markedly. This video is a testament to the effect of panretinal photocoagulation on iris and angle neovascularization in patients who have proliferative diabetic retinopathy, and is really a dramatic response in only 2 weeks. My thanks to my partner Young Kwan for capturing these pre- and post-laser videos. This 41-year-old man has long-standing, poorly controlled diabetes mellitus with neovascular glaucoma. He has had multiple episodes of panretinal photocoagulation. He has a permanently dilated pupil, and his neovascularization is now extended onto the crystalline lens. This is an unusual presentation of neovascularization onto the crystalline lens. This 21-year-old man has had diabetes since 2 years of age. He has severe proliferative diabetic retinopathy. We can see that his pupil is permanently dilated, that he has marked rubiosis iridis, and that he has ectropia uvea. On gonioscopy, the first thing one notices is that you can see the ciliary processes quite clearly. Anytime that you see this, you need to think that there's some pathology in the eye. In this case, it's the severe proliferative diabetic retinopathy that has caused the iris to be pulled out and up, exposing the ciliary processes. This patient had intractable glaucoma. You can see here that he has had a ceton placed in this eye. This ceton position is certainly not ideal because it's coming through the cornea. There's no space in the anterior chamber in this phakic eye to put a tube safely, except perhaps in the posterior segment. Where at a pseudophakic eye, one could put the tube behind the iris and in front of the intraocular lens. A good pearl to remember is anytime you put the lens on the eye and you see the ciliary body, you have to wonder why. This patient has neovascularization from radiation therapy. You can see fine vessels here at the pupillary margin, and on gonioscopy one can see active neovascularization with areas of open angle, but also areas with peripheral anterior synechia. Here we can see an open spot, and now we're drifting into an area that's closed by anterior synechia. One can see the vessels on the surface of the iris clearly here. This area is closed. As we come back a little bit farther with the gonio lens, we see an area that's open, another synechia here, and then an open area. This woman was on all classes of topical medical therapy and had inadequate control of her intraocular pressure. Because of poor visual potential, she underwent a cyclophotocoagulation. This is a good example of someone who has neovascularization and is in the process of closing their angle. Following a central retinal vein occlusion, this 80-year-old patient developed neovascularization of the iris and angle and neovascular glaucoma. We can see these large ropey vessels that are encircling her pupil and distorting the pupil. There are central posterior synechia visible here. She had a pressure to 55 millimeters of mercury, and her vision was light perception. Really striking vasculature here. And again on gonioscopy we see the same iris vessels. Most of her iridocorneal angle is closed. Inferiorly, we can see that the angle is closed, and we can also see that there's hemorrhage from these vessels settled into the inferior angle. This patient had a growing choroidal melanoma for which he underwent iodine-125 plaque therapy. He subsequently developed neovascularization of the iris, as seen here, with fine vessels at the pupillary margin. You'll also notice central posterior synechia. On gonioscopy, he has fine vessels in the iridocorneal angle. Notice that these vessels cross the scleral spur and branch over the trabecular meshwork. Normal vessels would not cross the spur in this manner. Neovascularization typically comes with a membrane that draws the angle closed eventually. In this patient, there are vessels but no synechia. One would expect that ultimately peripheral anterior synechia will develop in this patient, ultimately closing the iridocorneal angle. This 20-year-old patient has type 1 diabetes mellitus. He has extensive proliferative diabetic retinopathy and has undergone several episodes of panretinal photocoagulation. Despite this, he has extensive neovascularization of the angle. He has elevated intraocular pressure despite the fact that there are no synechia formed as yet. The elevated pressure, one would presume, is because of a membranous structure that travels across the angle with these new blood vessels. Vessels are present in this eye 360 degrees around the angle. The vessels cross the scleral spur and branch beyond the scleral spur, signifying that they are pathologic vessels and not part of the normal anatomy. Further in this video, it will be more readily apparent that there is a forest of vessels crossing the iridocorneal angle. Here at higher magnification is a particularly fine view of these vessels. Despite a patent laser iridotomy, this young hyperopic patient had narrow angles. We see when we indent a marked peripheral roll in the iris that is characteristic of plateau iris. Again, as I push in here, you see this roll in the far periphery, and as I let up on the pressure, that roll goes away. Here with some added fill light, it makes it even easier to see this far peripheral roll on indentation. This is really the hallmark of plateau iris. This patient is mildly hyperopic, about 1.75 diopters. His angle is slightly narrow, but we see the trabecular meshwork nicely. On indentation, as the iris moves back, the peripheral iris is held forward, presumably by the ciliary processes, giving this classic sine wave or peripheral roll that one sees in plateau iris. Again here, indenting, we can see this fullness in the far periphery. If there was not this plateau configuration, the far peripheral iris would push back just like the remainder of the iris. So the iris drapes over the lens, and then it should come up to the scleral spur, but in this case it drapes over the lens and comes up over this hump in the periphery, giving one the sense that this patient has plateau iris and an anterior ciliary body. This 76-year-old woman has a history of narrow angles. She's mildly hyperopic and had undergone laser iridotomies. On indentation, you'll notice that when we push, there's a peripheral roll in the far periphery of the iris. This is very characteristic of plateau iris syndrome. Here I am pushing, you can see corneal folds, and you can see a peripheral roll. As I let up on the pressure, the iris comes back forward, the folds go away, and the iris is again flat with a very narrow iridocorneal angle. Again I'm pushing, again you see the far peripheral roll of iris. I find indentation gonioscopy to be tremendously helpful in making the diagnosis of plateau iris syndrome. Again pushing here, corneal folds are present, and a peripheral roll in the iris. We let up, the iris returns to its normal shape. Here at higher power, again indenting, and we see the peripheral roll, and we also see the corneal folds.
After we just identify where the angle, then we need to look at certain points. First, we need to have an idea about the iris contour, the most peripheral part of the iris. It can be slightly convex, can be very convex, it can be flat, or can be concave. Slightly convex iris is the normal. You get the most peripheral part of the iris slightly convex. Flat iris, you can see it in two cases. In cases of big-sized eye, myopia, or aphakia, when the lens is not there, and also the flat iris, flat peripheral iris, you can see in cases of plateau iris. Plateau iris is a condition where the ciliary processes are thickened, enlarged, and pushing the peripheral part of the iris forward, and you get an occluded angle. The difference between the myopia or the aphakia and the plateau iris, here you get the iris drawn back and the angle is widely opened. But in cases of plateau iris, you get the ciliary body pushing the iris forward. So the iris is seen at the level of the trabecular meshwork or Schwalbe's line. In cases of myopia or aphakia, you can see the trabecular meshwork nicely. But in cases of plateau iris, the iris is pushed forward and you don't see the angle is closed. A concave iris, you can see it in cases of pigment dispersion syndrome and pigmentary glaucoma. In this UBM, you can see that the peripheral part of the iris is concave. On the slit lamp, you can see that the central part of the iris is more pushed compared to the peripheral part of the iris. We can watch this video, and you notice that the central area of the iris is pushed more forward compared to the peripheral part. This is the concave appearance of the iris in cases of pigment dispersion syndrome. And if the tension is high, we call it pigmentary glaucoma. So the first point is to have a comment on the iris contour. The second is to see the width of the angle, the distance between the most peripheral part of the iris and the Schwalb's line. How many degrees could be this angle? Then you see the structure visibles in the angle. In this drawing, here you can see all the structures, and this is the Schwalb's line here, and this is the trabecular area and the ciliary recess on the iris. Here the iris is a little bit forward that we don't see the ciliary recess. Here part of the trabecular meshwork is not seen. Here the iris is at the level of the Schwalb's line, and even here the Schwalb's line is not seen. So you get what is visible. Everything is visible down to the ciliary recess, or nothing is visible on the extreme end. Then you get a wide angle or a closed angle and grades in between. Here you can see this is the iris, this is the ciliary recess, this is the trabecular meshwork. Here nothing is seen. The angle is totally closed. Then you may meet any of these abnormal things. You may find peripheral anterior synechiae. This is the normal fine iris strands, while this is the widened, the broad areas of peripheral anterior synechiae. So this is to differentiate between synechiae, which are widened areas of occlusion of the angle, and the normal fine pigmented lines, the normal iris processes. Again, here we get the normal iris processes, and we get here a more widened areas of peripheral anterior synechiae. The second is new vessels. Sometimes we see vessels in the angle, and we have to differentiate between a normal vessel that can be seen in the angle and abnormal vessels. To know the normal vessel, let's see the anatomy again. We have a group of anterior ciliaries, they are 7. We get 2 vessels coming from one of the 4 recti, except the lateral rectus will give us 1. These vessels run on the sclera before reaching the limbus, 3 millimeters, pierce the sclera inside the eye. And we have 2 long posterior ciliaries coming from behind. They penetrate the sclera, move between the sclera and the choroid, sclera and ciliary body, to the ciliary body itself. So here, you all are familiar with this section. You get here the cornea, sclera, ciliary body, and as you see here, the iris is embedded in the middle of the anterior surface of the ciliary body. This is the anterior ciliary vessel. It is on the surface, running toward the limbus. Before reaching the limbus by 3 millimeters, it penetrates into the eye. And this is the long posterior ciliary running between sclera and ciliary body. They meet and make anastomosis to form the major arterial circle, which is located in the ciliary body at the root of the iris. From the major arterial circle, vessels run radially inside the iris toward the pupil. If this is the surface anatomy, this is the location of the major arterial circle. And these are the radial vessels running in the stroma of the iris. This is the drawing of the angle. You have here the iris, and this is the ciliary recess, and this is the scleral spare, and this is the trabecular meshwork. This is the location of the major arterial circle. It is embedded in the ciliary body. It is not visible. It runs circumferential like this. From this major arterial circle, we have these radial vessels running in the stroma of the iris toward the pupil. Now, we come to anormal vessels we may see. Sometimes this part of the major arterial circle is not embedded, and it is on the surface like this. So if you see a large vessel oriented circumferentially in an area, this is part of the major arterial circle, and this is a normal. Again, these radial vessels, sometimes one of these radial vessels or more is apparent. It's a large vessel, it runs directly radial, it does not branch. It's one of the normal vessels of the iris, but it's not covered with this stroma. And the third possibility, this anterior ciliary vessel. Imagine that it didn't come here, it's a little bit forward here to reach to the canal, to the major arterial circle. So this part will be visible, one major vessel coming through the sclera toward the ciliary body, not branching, run radially. So these are the three possibilities of seeing a normal vessel in the angle. Part of the major arterial circle, or one of the radial vessels of the iris, or the anterior ciliary is forwardly displaced. I want to show you this video. Here we get a blood vessel. This is reddish. There's only one vessel seen here, almost at 12 o'clock position. This is the anterior ciliary vessel visible. So normal vessels are broad, they appear for a short segment, they do not extend anterior to the scleral spare, they do not arborize on the trabecular meshwork. This is the abnormal vessels. They arborize, they run diagonal, they can extend anterior to the scleral spare. If they are on the surface of the iris, they are diagonal, like here. Here, this is an angle which is opened, but still you can see very multiple fine lines reddish in the angle. These are abnormal vascularization. The cornea is edematous, that's why the image is not that clear. But you can notice all these fine lines are arborizing blood vessels. These are abnormal vessels in the angle. The last thing is the amount of pigmentation in the angle. Normally there is some pigments on the normal trabecular meshwork. But abnormal pigmentations can be found in exfoliation syndrome, heavy pigmentation. It used to be segmented in areas of the circumference. In pigmentary glaucoma, it's a diffuse pigmentation all over.